Okay. All right. Good morning, everyone. Thanks for attending. This is the August 16th Behavioral Health Subcommittee of the Incarceration Prevention and Reduction Task Force. This is Dan Hamill, co-chair. I was going to say co-host, but that wouldn't quite be appropriate, I guess. I'm off camera because I'm just on my phone. My Outlook, my city Outlook does not work on my computer, so I don't have that capability at this point. So I apologize. We have one item today. I'm going to expand it to two items. Mike Hilly from EMS has been gracious enough to let us know from an EMS perspective some stats on fentanyl, and I think that we can have a pretty robust discussion. But for our first item today, that's going to be Perry Mowry, and he's going to discuss the BHGAT findings, and this is the behavioral health gap analysis that's been conducted over the last several months by a team of qualified experts. So Perry, go ahead and take it away.
All right, good morning, folks. Perry Mowry, Response Systems Division Supervisor and part of the Behavioral Health Gap Analysis team. That folks are aware, we've talked about this in a couple of different meetings. The BHGAT updated the sequential intercept model that was originated by the Incarceration Prevention Reduction Task Force. We looked at some of those documents yesterday in the full task force meeting. And one of the things, at least from my understanding, anybody can correct me if I'm wrong, was that the steering committee was going to further review the documents with the intent of adopting the sequential intercept model, and that becoming a part of the Incarceration Prevention Reduction Task Force. The title on it currently is the Behavioral Health Gap Analysis Team. Sequential intercept model, so moving it from the process of the BHGAT to the process of the Incarceration Prevention Reduction Task Force. My understanding about this is that the Behavioral Health Subcommittee was going to play a role in taking a look at the needs and recommendations chart. The behavioral health component of that, there's one that's other than behavioral health as well. And also taking a look at the feedback from the Stakeholder Advisory Committee, which this information was presented to on the 14th of July, as I recall. So I don't necessarily have a lot of specifics here in regard to the BHGAT, but certainly willing to answer any questions that I have. And also then really beginning to take a look at the needs and recommendations charts. That was included in your packet. And I guess I'll just generally start. The needs and recommendation charts that we're looking at for behavioral health was really a component of the rating that the Behavioral Health Gap Analysis team did in terms of the highest priorities identified as needing to be further developed or addressed. And so we took those high priority items from the sequential intercept model, placed them on the needs and recommendations chart just to simplify things a little bit, and then broke that into the need gap statement, recommendations relative to that need gap, the intended outcomes, and then we began to work on the estimates of resources needed to implement those recommendations. And at least, again, from my perspective, this body of work returning to the subcommittee and the Incarceration Prevention Reduction Task Force as a whole to continue to provide feedback and address steps that are occurring in roughly three different areas. The community behavioral health services area, which is the first set of three need gaps that were identified. Housing services for at-risk populations that had also 3 areas, need gap areas. And then finally, the jail facilities and services specific that has 3 as well. And then, I'm sorry, there's actually 4 sections in the need gaps chart. We also identified specifically re-entry services. One of the things that I will say is that we were able to develop the component of these need gaps charts, the estimates of resources needed to implement the recommendations. We were able to develop that portion of the need gap chart further in the community behavioral health services, and also in the jail behavioral health services. And so I think that folks can, see that and review that. So my understanding again of the discussion is really around taking a look at those needs and recommendations charts. There's also a document that was included in the packet, the feedback from the SAC members from our 7/14 meeting, and then proceeding from there as far as next steps to be taken. That's the information that I have at this point. Certainly open to thoughts, comments, questions, directions.
Committee questions? I can only see like 3 people at a time or 4 people at a time. So if anyone has questions, just go ahead and speak up.
Perry, I assume this document takes into account the plans for another facility on Maplewood.
I'm not sure, Brian, if I'm understanding your question.
My understanding from Alicia Rule is that they've secured some funding for a future treatment facility in Bellingham on Maplewood.
I don't, go ahead, sorry.
No.
I don't have specific information about that. I know that I've heard some discussion. We did not discuss that specifically during the behavioral health gap analysis team work per se. But it may, certainly we have acknowledged that this is a living document, and we can certainly absolutely add predominantly, the work really existed in tier B and tier C. That is those programs in place with resource shortages, and also programs that are recommended but not in existence was the focus. And so that can certainly be incorporated into the process of updating the sequential intercept model, and could certainly be a part of the behavioral health subcommittee or the incarceration task force as a whole.
Okay, is there some uncertainty about that, or is just, I know it would be a number of years out, but.
Right, and so what I'm saying is that I don't have current information on that, Brian. I apologize, just in terms of where that stands. And so it's just a lack of knowledge on my part, as opposed to uncertainty about the continued process of it.
Do any other committee members have more specific information about that?
Not a lot, Brian. That possible facility has been mentioned very briefly a couple times over the last couple of years. What I recall from it is that it was intended as a private pay facility that would not take Medicaid reimbursement, and that was a problem in terms of its applicability to the population that we're dealing with primarily. So I don't know what, I don't know if that is true, was true, but it would be a factor if it were.
Definitely. All right, I might look into that a little bit more before the next meeting, but thanks for the discussion. Appreciate it.
Jill, would you mind sharing screen of the portions of the SIM documents that Perry was referring to so that we have that?
Can you see that now?
Yes. Perry, is that adequate for the focus of the discussion you want to have?
It is, Stephen. Thank you. And Jill, if you could move down to the first portion, I've got it here too, so I can just jump ahead of you a little bit. The community facilities and services. So we can just touch base on, again, the need gap is a repeated, a little more elaborate statement of the need gap that was identified on the sequential intercept model, our first column. Need increased access to mental health and substance use disorder, SUD assessments, on demand, no waiting. One of the things that obviously we're running into at this point, and folks, you know, we've belabored this point certainly, is workforce issues and challenges that are there. And so the intended outcome being the number of people, an increase in the number of people prepared to enter treatment for mental health and or substance use disorder, and also a reduction of criminal legal system involvement due to untreated mental health and or SUD. We know that a large number of individuals that that are going through the judicial system are struggling with both significant mental illness as well as substance use disorders, and oftentimes that, you know, that process is cycling. So I'll real quickly go through the bullet points of the estimates and resources that we were able to come up with in terms of our thought process within the BHGAT. State legislature passed funding bill, which created an infusion of $100 million for behavioral health agencies across the state for workforce support as of July 1. Also, Medicaid rate increase as of July 1, 2023 is pending, plus infusion of the additional $100 million. Hiring, including hiring wages, better benefits, incentive pay, etc. Incentive pay for working with people in the criminal legal system or who are incarcerated in jail currently. Use of current wait lists to determine if capacity will meet demand, and providers offer a model of services which initiates screening and assessment diagnosis in the jail. So just real generally here, you know, one of the dynamics of this need gap is that we obviously have some pretty well established relationships with the providers in the community that do provide both mental health resources as well as substance use disorder resources. And so we do have some meetings that we established through the health department with the entities that I'm making reference to, and opening communication. One of the things that we've done, for example, we have a bi-monthly meeting for crisis services as well as mental health individual entities being involved, and continue to communicate with them, for example, about what their current caseloads are, what their access is as far as new clients, and you know, continuing to have that communicating amongst themselves, as well as communicating with the response systems division within the health department around those resources. The challenge here is that in order to address this need gap, this is working with existing providers. The county, the health department, for example, does not specifically pay for assessments for mental health and needs and or substance use disorder needs, but that is paid through Medicaid, as folks are aware. And so it's that challenge of approaching the providers to further develop this need gap issue in terms of assessments on demand, no waiting. I mean, we're really very much identifying that individuals that are within the community need to have a very quick access because sometimes the opportunity to address challenges is fairly slight. It's fairly short that the individual may, for one reason or another, be more motivated to be open to that assessment. The assessment is necessary in order for a full assessment is necessary at the agencies in order for them to follow through and have the information needed to bill for Medicaid when they do engage the services, whether that's assessment or from there the recommendations and ongoing services. So that's the challenge that we have in terms of I'm speaking we in terms of certainly the county at large, but in looking at this and saying, okay, so how do I support that process of engaging providers at this point in time with the challenges that they're experiencing to have these on-demand assessments that there's no waiting there. So that's just the first one and sort of the challenges that we wrestled with in terms of discussion. I think that as the workforce, and there are certainly some attempts being made in terms of further developing workforce, and that as that issue reduces, we will see higher access to our behavioral health providers in terms of assessments and actual intakes.
Perry, do you know if that 100 million for workforce support has actually hit the streets as of July 1st?
I don't, but I'll make a note in terms of following that up.
And I'm wondering, and maybe Michael is the only real provider here this morning. Michael, I wonder if you could address whether Lake Whatcom has any steps rolling out to take advantage of some of this money or plans for screening and assessment, perhaps?
So according to the admin notes, they're discussing it. So it's currently in discussions now, I guess, to try to figure out a plan or something like that. But outside of that, I do not know. I haven't heard from any other agencies in the community about how they plan to roll that out or what that would look like. So yeah, I'm unsure at this point.
Thank you.
Hey, I want to jump in here real quick. Stephen, you're stealing my thunder a little bit. I was going to put Mike on the spot about asking that exact same question, but I'll ask another one. Mike, what other providers are there, just so we have this in the public record, what other providers out there aside from Lake Whatcom are providing similar services?
Sorry about that. My mic wouldn't unmute. You have Sunrise Services, Lifeline, Connections, and so Catholic Community Services. They do mental health, I believe, in substance use. I'm from Pierce County down there, so they do both actually down there. I believe Catholic only does. Yeah, they do substance use as well. So Sunrise, Catholic, and Lifeline are who we deal with a lot. Obviously, Lummi has some SUD as well, but those are kind of the main top folks that we deal with consistently.
Okay, thanks. And it would be nice to have the service capacity of all of the organizations that you just listed, in terms of how many people can access services at any given time. And then I would add to that the crisis stabilization center, one central at the hospital, very, very limited, not really, well, I guess inpatient to a degree, but it'd be nice to have that. I don't know who can wrangle that information. I see that Mark Gardner is on the call. Mark, you're listed as an attendee. I don't know if you can turn your mic on, but if you could maybe take a look at those organizations and reach out at some point. And it doesn't have to be before the next behavioral health meeting, but the one after that, I'd like to have an assessment, given the fact that Perry's cited some pretty, what I would regard as very interesting notes here in terms of what this infusion of money will look like. And then Perry, my question to you is, what is the Medicaid reimbursement rate? Do you know that percentage?
don't have it here in front of me, Dan. I apologize.
Dan, Jill here, Jackie Mitchell and Mark Gardner both have their hands raised.
Go ahead. Mark, go ahead and respond, and then Jackie.
Yeah, Dan, I heard that request in general, but I didn't get the specifics of the organizations you wanted me to look into. Sorry about that. I was just
That's fine.
Generally listening.
That's okay. Mike, can you go ahead and just list those organizations, the ones that you mentioned?
Sunrise Services, Catholic Community Services, and Lifeline Connection. Those are the main three in the community here.
Okay.
And for mental health, I would add Compass Health.
Yeah, Compass Health and Lake Wacom are pretty much the mental health folks, especially serious mental illness.
And CMAR too provides services for people with serious mental illnesses and substance use disorder services. I was just going to respond to, I think it was Stephen's question earlier about the 100 million, which has not hit the streets yet. I was just in a meeting last week, regional meeting, provider meeting, where the state healthcare authority discussed that they were still working on the methodology. And so once they get that methodology going and determined, then they'll be able to send this money out to the providers so they can utilize it. And then as of January 1st, there's another infusion of funding, which I think is stated in the second bullet point. And so hopefully they'll be able to use pretty much the same methodology so they can get it out on the street faster, but I don't know what their plans are specifically for that. So we actually have a list of agencies that provide behavioral health services, both mental health and SUD, 2 different lists. So folks could actually look at that list. But I think it'd be a little premature to go out and ask what their plans are until they know what the state is doing with the funding and what their methodology is.
Thanks, Jackie. Yeah, what I'm trying to do is get a roadmap here, just based on Perry's presentation here this morning. It looks like there's some positive news resource-wise with behavioral health treatment options. And then Mark, I would add one more. I don't know who operates this clinic, but there's one on Northwest. It used to be Northwood Hall. It's behind the Big Lots. There's I think it's a methadone clinic, and I don't know who operates that. I don't know if Jackie or...
Yes, I do. It's Acadia, which is a national organization that runs a lot of methadone programs. It's called, I think it's called Community Treatment Center is their local name, but Acadia is the national organization that runs it.
Okay, so like that organization is like basically hidden from view, and I mean, I don't mean that, I mean semi physically, but also that's not on our radar screen. Like that just did not come up in the list of providers here that we're talking about this morning. So I'm wondering if there are others that are out there that we just don't, that's just radar screen. It would just be nice to have a full assessment of service providers when it comes to SUD in particular, but also, I mean, to some extent, mental health. And then Mark, I would add one central Peace Health St. Joseph facility to that list.
Yeah, Mark Gardner has his hand raised again. And Mark, go ahead and speak up. Dan's doesn't have visual video today. So.
Yeah, go.
Yeah, I was just going to say, I'll work with Jackie to get a sense of the overall picture and make sure that we can pull together some documents that would provide some background on this. But sounds like Jackie has some of the basic information. So hopefully we can work together on this, if that's okay.
Sure. Yeah. We have lists of all the providers in town. We may not have Peace Health listed because they don't just accept anybody in the community. I mean, that agency, their outpatient program exists solely to ensure that they have something for people available as they go out of the out of Peace Health and out of the hospital. So we may not have that listed. But yeah, absolutely, Mark. I'll send you what I've got.
Great, thanks.
Okay, and Perry and Jackie, is that okay? I don't like giving directives to people who don't work for me. Is that okay?
No, I think that that's helpful, Dan, and just sort of framing up. We obviously need to know current capacity. I mean, that's going to be a bit of a moving picture, but I think that if we got the larger players, and again, you know, Jackie has the list and can work with Mark, that would be, I think, helpful information for us to add to our estimates of resources and needed to implement the recommendations. So we can update this needs gap chart with the information that Jackie and Mark are able to compile.
Okay. And then one other question pursuant to that. So the way station, Unity Care Northwest is opening up the way station on State Street, I think within a year. It would be nice to have a understanding of what that, what the service options are there, if there is any SUD, or if it's just purely kind of patients who are recuperating and then, you know, moving on to a different place. It'd be nice to understand if there's behavioral health services offered there, or if they will be.
Dan, Chief Tank and Stephen Gockley both have their hands raised.
Go ahead, Chief.
Yes, and thank you. So about a year or so ago, there was an intern that worked in Malora's office that created a kind of cheat sheet, if you will, for law enforcement with the different resources here in Whatcom County, and I believe in Skagit County as well. So in terms with Councilmember Hamill asked about, I believe something like that has already been started, but to what extent, I don't know. But and I don't have that intern's name either. So having something like that, and it was kind of a pilot project. I don't think they rolled that out completely with law enforcement, but I do think that that would be a start. But also to Dan's comment, and I know for sure up here in Blaine, there is some confusion even within my officers of when you have a person that needs service type A or service type B, I'm just using that generically, where do we start? So having a list, and really I think for me with my officers, just having some different scenarios to talk about, you know, if this happens, or if you run into this particular situation, what do you do? So from a law enforcement perspective, that's what we're going to start doing, is to have different scenarios, because it's so different and it changes month to month. Thank you.
Thanks, Chief. Go ahead, Stephen.
Thanks, Dan. I'm riffing a little bit here, and I have no idea whether this has even a single foot based in reality. So I guess I'm looking at Perry and Jackie, perhaps. You know, there are two ways we could approach this chart that we're looking at. One is we could let the provider agencies sort of figure out their own way of dealing with all of this and the money and where it's going to go and which workforce portion they're going to support. But I'm wondering whether there's a way to sort of more collectively address the need and the need that the task force is working with, in particular across agencies, so there's a little more concerted effort going on in applying this money where the community might need it most, rather than just where individual business models directed. So I don't know if there's any chance. I know the county is pretty reluctant to sort of step into agency business, but I'm wondering if there's some way that the task force itself could meet with the agencies and talk about how important these priorities are to the community. I don't know. I'm just wondering if there's some way to get more bang for the buck out of this by working together rather than passively waiting to see what happens individually with the agencies.
Perry, you got a response?
I do, and I think that it is an important thought, Stephen, and I think that one pathway, anyway, the Response Systems Division has some pretty well-developed relationships with the providers and regular meetings, as I had mentioned, that are oriented towards crisis response as well as behavioral health needs. And I think that this document, as it is fleshed out just a bit, the needs recommendations document would be a good guide post as far as having that discussion, initiating that discussion with the providers and saying, listen, you know, here's the information that we've come up with that are the needs, and at least initiating some response back from that group, and then maybe formalizing those meetings a bit further with, I think, number one, having the information of what is the capacity at this point in time, what are the plans, and, you know, and also obviously speaking to and referencing the funds that are coming in, as well as other, you know, support systems that are available to our providers, because that's where the need is at. So I think that this document really lends itself to having that discussion and then further developing a support approach from the county at a minimum, with making certain that the providers are understanding not only from a business model, but from a community standpoint.
So I guess my follow-up question, Perry, that's helpful, is do those meetings, do those communications the county has with the providers, I mean, for instance, Michael mentioned that there are discussions upstairs in management that, you know, that he hears about, but he's not privy to, I gather. So I'm wondering if the Response Services Division discussions are with the actual service delivery level of people, or whether they're with the management people who actually be making these decisions. And I'm just thinking, I'd like to put this as forcefully as possible before that upper level of decision makers.
So possibly there's a fairly large, I think the distribution list is well over 100 individuals for these bi-monthly meetings that occur with the behavioral health providers, and it includes both upper structure of those entities, at least in terms of the invitations, as well as the clinical supervisors and obviously even the individuals that are providing the services as well. So we're very inclusive of that. But the thought strikes me that possibly an additional meeting be arranged, you know, relative to and inviting those administration components of the behavioral health providers, you know, that we have listed as a process of presenting this needs gaps chart and discussing some of the intention and interest that the task force, as well as the health department Response Systems Division has in terms of further developing the resources within the community in a more in a sharper point, you know, if you will, as opposed to a more general approach.
Can I just add, yeah, I like what Perry said. I think we can take it to some of the provider meetings that we have. I think that it's also, we might also be able to come up with some guidelines and, you know, have some hope that agencies might follow those for our specific area, Whatcom County, where we have higher cost of living than most areas of the state. But we have to also be cognizant of the fact that most of those agencies have tentacles in different areas of the state. So it's not just Whatcom County they're looking at. It's also, you know, CMAR is all over the state. Compass Health is very North Sound centric. Lifeline touches both edges of the border, north and south border of the state. So we just have to be cognizant of some of the issues that they are all dealing with. And ultimately it's going to have to be their decision. But I think what you're suggesting, Stephen, is there a way to sort of mold their thinking a little bit about Whatcom County and kind of make some pretty strong suggestions about how the rollout might help the situation in Whatcom County. So that it might be possible to come up with some guidelines that we could ask the agencies to follow, maybe.
And my question came from the fact that it's a pretty unique situation that we have an infusion of money like this. And it's a pretty critical time to be addressing this in the agencies and in the community. And I would just, you know, I'm going to adopt Dan's wise position of recognizing that I can't direct other agencies to do what I think is a good idea, but I would encourage the county in whether it's guidelines or a meeting with upper level people to be as assertive as possible for the importance of this to the task force and the importance of the task force's work in the community at you know, some of the most acute points in the arc of somebody's treatment needs. So I'm just trying to be encouraging.
Got it. And I think at least if Perry agrees that we can certainly talk more about this and kind of see if we can figure some ways around it. I think it's also complicated by the fact that some agencies have union shops and some do not. And, you know, there's just all kinds of factors they're dealing with that we don't even know about, but we will certainly try to understand their issues at a much deeper level and see if we can find a way to edge our way in. I think, Perry, you think that might be agreeable?
Yeah, I think the key factors, you know, that it's from this discussion that are, you know, I'm getting some clarification is obviously the funds that are becoming available, and also the work that's been done around really identifying the needs and gaps that are occurring within our community. I mean, this is obviously more preventative intervention as far as diverting individuals from criminal justice system. And within, so I think that taking that information to them, taking it beyond, you know, the task force and the community in general, but having a very specific discussion about, okay, we've done a fair amount of work and identified some real needs for the community, and now we want to come alongside of you and talk about and bring that information to bear. And I think that, you know, again, as I'm sort of developing this thought process, to schedule a meeting that is, you know, around oriented towards administrative entities of our providers, and including representatives of the task force to, you know, to speak to that as well. I mean, I think that that's an important step in taking the work that the task force has done thus far with the SIM and the needs and gaps. It's a great place to start.
Any other thoughts? Okay, seeing now, go ahead and kind of follow up a little bit on something Chief Tank mentioned with his officers doing, you know, scenario A and scenario B. If this happens, then you do this. If this next thing happens, then you do this other thing. What I'd like to ask for committee is your permission in creating an agenda item that is pursuant to what Chief Tank mentioned in terms of what law enforcement does when they're addressing a behavioral health issue, what the current practices are and what the intent is moving forward with Blaine Police Department. And also I'd like to invite, I know Under Sheriff Chadwick's not on the call today, but I'd like to invite Whatcom County Sheriff's Office to go through their responder program in terms of what the steps are with referring someone to services. And I'd also like to talk to someone in the response division of the Whatcom County Health Department, what the intentions are with the alternate response team in terms of what services will be recommended for a person who's experiencing a mental health crisis or a substance use disorder crisis. So committee, I'm asking for your head nods or your thumbs up on that as an agenda item for a future meeting.
I do want to clarify is that we have not started that scenario-based training, but the idea is that we should begin to start that type of training and to put together a program specifically designed to be able to triage and think about some of these different situations. So I totally agree with it, but I want to be clear that we have not started that yet.
Okay, Chief, I get you. I hear you. Yeah, I get what I want to have is an understanding of as departments move towards this type of option. The old option used to be jail or the hospital, right? Those are the two choices. Now we have the Crisis Stabilization Center as an option. What further options are departments looking at? Is what I'm asking, Chief. And I realize I hear you full on that that it's not operational yet, but at some point you're going to have to make some decisions on what options you're going to have for your officers. So that's what I'm asking. Does that make sense?
Total.
Okay. Committee, are you all okay with that? With that as an agenda item for a future discussion? Okay. I see head nods.
Yes.
I'm scrolling through. I'm swiping my phone and looking for agreement here. So okay. Very good. Go ahead.
A couple of things that I can add to that, Dan, and Jackie is involved in this to a certain extent. The Response Systems Division is compiling a set of trainings oriented towards first responders, law enforcement, relative to the resources that are in place and are developing. So the training is, the intent of the training is that it's short, that it is oriented towards a first responder, law enforcement, and that it is accessible online, kind of orientation. But I also think, and I've definitely heard from Chief Tank and other entities, that a quick reference card, cheat sheet that goes in the visor that can be quickly accessed by law enforcement is a really important almost decision tree process of, okay, this is what I'm dealing with, what are my options here, and then that information and contact. And so I do recall the development of that. I'll just refer to it as a cheat sheet right now, or a quick reference guide, and the further development of that. I think that's a really important piece. I mean, the training is great. It's going to be really important, but I also think that a quick reference guide is going to be super helpful for that, because as you mentioned, Dan, that there are new and developing the co-responder program with the Sheriff's Office, the alternative response team, and also obviously Grace and Lead, and how, those are accessed in addition to the Crisis Stabilization Center. So I think almost a decision tree quick reference guide is going to be helpful, that would encompass the information that's being developed in the trainings at this point.
Okay. So sorry about that. What I'm trying to do here is I'm trying to fly it at about 30,000 feet when it comes to trying to explain to the public what it is that we're doing. I'm gonna turn my camera on real quick here because I finally figured out how to do this. Okay. So we had a meeting with the Incarceration Prevention Reduction Task Force communications folks. Pyramid, I think, is the name of the company. Is that correct, Stephen? You're nodding yes. Okay. And so what I'm trying to do is to explain to the public when their father, mother, son, daughter, whatever, has a behavioral health crisis, or the person that's on the corner having a crisis, what happens to that person? And we have changed the way that we respond. We are changing the way. We're not there yet, but we are changing the way that we respond to those in crisis. It's no longer just, and I don't mean just, but it's no longer a badge and a gun showing up to every call. It is a co-responder or an alternate response. And I want to be able to explain to the public what that looks like. Where does that person go? And what services are they being provided? And so that's really, so I'm looking at it through that lens of, since we've evolved greatly in our process here. And this is one of the things that I think is one of the highlights of this task force, in terms of being able to say, hey, look, we thought about all this, and here's the response that we have. And so that's where I'm coming from. I hope that all makes sense. Okay. Sorry, I'm outside. My wife is on a separate Zoom call in the house. We have an open floor plan in our house, so we can't do two Zooms in one in our home. So I'm outside. So I apologize for traffic that goes by. We live in a working class neighborhood. Any other thoughts or comments pursuant to the subject? Okay. Okay, I see none. Okay, I'm going to move along here. I think I don't know what time it is. I think it's like 9:40-ish or something like that. So I want to move to the next item. We had invited Bellingham Police Department to come and discuss what they're seeing on the streets with fentanyl. We did not hear back. So I'm hopeful that we can have them at our next next meeting to have a little more close-up discussion on that. But Mike Hilly has agreed to provide from an EMS perspective what they're seeing with fentanyl. And I want to frame this discussion. I think it was 2 sessions ago, the state legislature, well, pardon me, the state Supreme Court rendered the Blake decision probably a year and a half ago, might be 2 years now. And the state legislature in one of those recent sessions tried to provide some kind of framework in terms of how to address the Blake decision. So Blake decision makes simple possession basically a misdemeanor offense. It doesn't, and so police WASPIC, the Washington Association of Sheriffs and Police Chiefs, rendered a very narrow perspective on the Blake decision. And what I'm seeing on the ground here is that people are not being they're not being held for possession. And so what's happening is, I'm going to put this up here. This is what police officers give to a person who they find with a drug on them, what was formerly a felony possession. They give them a business card with a 1-800 number on it, and they say, go ahead and call this number and get into a recovery program. And they give that to them twice, and on the third time, I believe they get a ticket or a summons to go in front of a judge. It's really frustrating to know that one of the most addictive drugs that's out there, fentanyl, on the streets, I believe it's 50 times more powerful than heroin. And handing someone a business card saying, go ahead and just call this number, just doesn't seem like an effective treatment option to me. And I'm not being, I don't mean to be, short with this, but I think that we're in an uncharted waters, and I'm very worried about people's physical health. I know that our first responders have Narcaned several people back into life, basically. And and Mike, I'm gonna turn this over to Hilly. I'm gonna turn this over to you in a second here, but I wanted to frame that we have a very addictive substance on the street right now. It's unlike anything that we've seen in recent years, and just really concerned about people's well-being and the associated crime that is that's pursuant to that. So Mike Hilly, do you want to maybe just walk us through a little bit of the EMS perspective?
Yeah, good morning, Councilmember Hamill. Appreciate the time. And actually, it's kind of the timing on this is appropriate. I'll share my screen here and bring that up. So let me expand a little bit. Hope everybody can see that. Is that okay for everybody?
Yeah, Mike, you're good.
So yeah, thanks. So just a little background. So I get usually a bi-monthly report looking at all the opioid deaths around the state. Not all counties are reporting, and actually up until December of 21, Whatcom County not was reporting. So this report is an output from the medical examiners up and down the I-5 corridor and a little bit across the mountains, where they submit monthly information about what's killing their patients related to overdoses. And so this bulletin is put out by, well, it's funded by the Coverdell National Forensic Science Improvement Grant. However, it's produced out of King County from this King County ME's office, where they collect all this information. They've done a really good job with this, and it's just a good overview in the state. They give some, you'll see at the front of this report, they give us some of the leading headlines that are going on, not only locally, but in national, and what other areas are doing to combat the opioid epidemic. So as you kind of go through this is a report. It accumulates every month with additional, but this is a July 21 to July 22 report. Dr. Allison Hunt agreed to start reporting Whatcom County in January 21. And so this is just a couple of different ways to look at this data. But I think this is the most significant look at what's going on in the state, this pie chart, where fentanyl represents 35% of the overdose fatalities in the state. And you can see methamphetamine comes in close behind it. So keeping in mind, these are deaths related to drug overdoses. I will say many times these are polydrug overdoses, but during the toxicology report, you're able to kind of find out what the most prevailing substance was involved in that death. But many times these are polydrug overdoses. And so this is what's trending in the state and what's going on. Now, as we kind of scroll down here, we can, this actually just a different way of looking at it, but many times you have these combination overdoses with fentanyl and methamphetamines, and these are 544 death cases in the state. And then you'll see this 198, which is a fentanyl and cocaine mix, or sometimes a fentanyl and heroin mix, or methamphetamine and heroin, and then methamphetamines and other opioids. And a lot of times you'll have benzos mixed in with that as well. So this is kind of a little bit of a breakdown of the highest killers, in the state at the moment. And this is another way of just looking at it. You can see the line chart trending, but once again, you'll see the fentanyl just climbing and climbing and climbing over the heroin and to some degree the methamphetamines in this time frame. Once again, you can see by single overdose, 439 cases of, basically fentanyl only overdoses to the 288 methamphetamine overdoses. I think this other RX opioid is something to keep an eye on. One of the things that I know the doctors are talking about, and actually in a state meeting yesterday, not related to opioid overdose, but just general epidemiology, was that you're seeing a number of older folks, people over 60, having overdoses. And many times it's related to the narcotics are given to go home for chronic back pain or an injury or post-surgical, whatever it is. And one of the now many doctors, when they're sending older folks home with prescription opioids, are also sending them home with a Narcan kit in case they mix up their meds that day or accidentally overdose, or maybe don't feel like they took enough, and then when it does hit them, they're somnolent or near overdose. And so we're seeing an increase in older people overdosing for various reasons, not necessarily related to a long-term abuse problem. Once again, this is just a little bit, the opioids is a general category. They include your fentanyl, your heroin, your methadone, all those types of substances. Or 546 deaths in the state in that time period. And in methamphetamine, purely 288, cocaine down to that 53. So for Whatcom County, so this is just another way to look at all that. The yellow is the fentanyl, I'm sorry, the blue is confirmed fentanyl, and then suspected, usually waiting on toxicology results. And you see back in July here, waiting on a large number of toxicology results to come back in to make those compilations. So, but down here, you'll see a little bit of reporting for Whatcom County. So Dr. Allison began reporting in January 22, and these are overdose fatalities in a given month for Whatcom County. These are confirmed obviously through Dr. Hunt's office and toxicology. And I know when she is doing these investigations, we send her the EMS reports too, if EMS is involved in this, so she can get an idea of what this looked like on scene, if there's other contributing factors to that death. So these are our death numbers that are contributing, and this contributes to the whole state reporting there. For Whatcom County, I noticed, actually, we're not in the 100,000 yet. Where are we up here? I thought we were in the, we hadn't reported in the 100,000, the rate per 100,000. And I suspect that's because we just haven't been reporting long enough in the county. And then this is, this is actually just kind of supports a reason an OD was suspected, usually by what maybe either law enforcement or EMS writes in their reports on scene is related to that death. The ME takes that information once again from those records and tries to compile what exactly made a person log that this was an overdose. And you can see a lot of it's wrapped around the history of the use of OD. Usually these are patients or people we've seen before, maybe woken up before. And then on scene, obvious drugs or paraphernalia on scene. And sometimes, this is actually when you see somebody overdose and the pills are actually laying on them or the needle's still in the arm type of thing. And then as it trickles down, it becomes a little bit more ambiguous of what contributed to that overdose death in this reporting. So, and once again, overdose, previous people that had previous overdoses or no overdoses. Sometimes we chart that, sometimes we know that once again, that's a collection of information that can be sometimes ambiguous, and we have to prompt the EMT, paramedic responders to kind of log or note that so we can have more information whether that person overdosed or not. And actually, we can go back into our own records and image trend, which is our electronic patient care reporting system, to see if they had previous history in that overdosing. And then, was a treatment provided to those patients in the past? Was there a previous recovery support? Had they been in some type of rehabilitation or attempt at getting off the opioids or the drug that they're using? And then you can see some that were referred, this is statewide, from primarily the EMS system that could have got referred to services from that contact. And this detox area is where I know that our EMS groups want to work. And in reference to your comments, Councilmember Hamel, when we see these patients out, we want to direct them to a better facility, if you will, as opposed to the emergency department, unless they have a life-threatening thing that might create a better narrative for getting folks to actually go get help, as opposed to just leaving the scene once we wake them up against medical advice. And there's a large amount of people that do that. They don't have to go to the hospital. That's their right. EMS responders try to have that conversation and talk them into going, but many times they won't go. And so that's against medical advice. And so these are sort of the numbers that you'll see that do get referred. I can tell you locally and a little bit anecdotally is on some months, it's been almost 50% of where the patients will refuse treatment. Other months, they have a little bit more success of getting more people to the hospital, at least for a quick engagement. But many usually walk out of the hospital once they're feeling better. So a little bit of breakdown, once again, at the state, gender, and ethnicity of the decedents. These are people that died as related to their demographics. And I think this is an interesting graph here if you look up the various demographics of people that are dying from the overdoses. And then this is just a manner of death. And sometimes you have some other contributing factors such as accidents or contributing car wrecks, people that were on opioids or actually alcohol or whatever contributed to their accidental trauma with their death as well. So this is how much Narcan is being used at the scene. And Narcan used on by people that were decedents. I'll say this is a little misleading in the sense that this information is given to us. So locally, I get an email or a text in the email every time fentanyl is given in Whatcom County. And sometimes I get 3 or 4 texts a day. Having said that, though, we use Narcan for a variety of reasons. One, sometimes it's just a rule-out drug for a sudden cardiac arrest. So many times these overdoses come in as a sudden cardiac arrest. Then you get there and you realize, okay, this looks more like an overdose. But sometimes in just a normal cardiac arrest of a person with heart disease, you'll see responders giving a Narcan just as a rule out, because you just never know at this point who might be on narcotics or not. And it doesn't hurt anyone. And if it, does, if Narcan or, opioids were present in the system during a cardiac arrest, it will help that cardiac arrest or that resuscitation be more successful. But so this is a little, I won't say misleading, but there's some caveats to understanding how Narcan is used in the field and some of the ratios related to it actually being an opioid overdose versus a cardiac arrest from, cardiac disease. So, and so we get intel. I will say over my years, so I, for those that don't know, I was a paramedic down in King County, just short of 30 years. Back in the late 80s, early 90s, we could always tell when the heroin was flowing through, because generally it came from the north out through Vancouver, et cetera, and it trickled down the I-5 corridor. And we'd start hearing reports from our friends up the I-5 corridor saying, hey, we have a little batch of heroin coming down, and we'd kind of know. And so all those years, we sort of just informally shared a lot of that intel, which is actually the output of what's going on with the King County ME's office to better share that information as it comes available to understand where the trends are and where maybe some shipments of fentanyl have come in to the community. And the sheriff office speaks on that frequently as well. So this is just some intel up and down I-5 corridor, things that we can see. You can see that the ME has contributed to this photo collection back in May of 22 with some photos. And once again, this is to kind of understand how it's being delivered, what those blue M30 pills are looking like as they come out of the presses, and then other ways people are ingesting, smoking, shooting this stuff in the region. So, and here's some more photos of what this is looking like once again around the state, you know, and this is just great information to put out to the providers to keep on the lookout for these various forms of opioids and meth and crack and other substances that are moving through the community. So, so anyway, this is a great report. I get this every other month. I share this also with Joe Fuller's group over at the Opioid Task Force, where they talk about. And one other thing I just want to let this group know is that from the EMS office, we think about this a lot. So two things. One is that we're working with Lacey McCauley of the ART team. And we have a generalized, we haven't really got into the meat of this conversation, but we have a generalized idea that we like to offer some on-scene counseling or services once an overdose happens in the field. So EMS goes out, they wake up an overdose. This ART team could potentially respond as well. Maybe an SUD person can have a conversation with that patient and say, hey, you know, we understand you want to go to the ED today. However, we have some alternative services we could offer you. And if today's today, we'll be glad to take you over there and get you in it. And maybe this will be a bridge to MAT and then some longer, you know, more quick services that may latch on. Because to your point, Dan, yeah, handing a card to somebody, I don't know how you navigate that. Everybody picks up the desk, they pick up the equipment, they leave, person standing in the street with a card. You know, what next? And so there's not a really great warm handoff on that. So working with the ART team, we'll develop that over the next fall once those guys, you know, get up and running and those teams are mobilized. But there's a strong conversation and we'll want to do that. And there's been some success with EMS services back east with that type of program as well, navigating the services. And the last piece of news I have is that EMS office just received a grant for about $180,000 from SAMHSA, that's the Substance Abuse Mental Health Administration from the government. And this $180,000 is oriented to providing 2 emergency medical technician classes that would recruit people from actually some of our more vulnerable communities or underserved areas, and it would help create some workforce development for people that may not have otherwise have an interest or access to becoming an EMT. And the caveat on this particular training is that there needs to be 2 separate modules developed that will be inserted into the curriculum. And one is a module related to substance use disorders and how to use fentanyl strips and how to teach people how to use fentanyl strips. And then the second part is to develop a module that creates a higher level awareness for mental health issues when we see patients out in the field. So we're developing those 2 curriculums now. One of the targets is the tribal community over at Lummi. We want to see if maybe they would host an EMT course and see if we maybe will recruit members of the community might looking for an EMT career and a springboard to that along with these modules. And then also out in the rural community, maybe East County, where we would do a similar thing out there. So we'll be able to report better on when those classes will happen and what those curriculums will look like. But we need to bring the heightened acuity level of our providers out there for understanding and responding, as well as create an alternative way to support that information by having patients that are willing to go to an alternate destination for their overdose and have some engagement with the social workers or SUD workers. So hope this is helpful for you. Jill Nixon has a copy of this and we'll email, she probably already has emailed it to you. And this is just great information, I think, from the region. And I'll stop sharing my screen here.
Thanks, Mike. Committee questions.
I just want to say that was a great presentation. That was some really good information. I'm gonna share that with my staff. We get a lot of folks coming in on the inpatient side, positive for fentanyl. We're starting to see it a lot more. Yeah, so great information. I'm gonna share this with my team. Thanks.
You bet. Actually, I would add one thing too, as we talk about this. So the one thing that we've learned, and I know all of you have some good experience with Jeremy Morton, who's done a lot of great data analysis in several sectors of this work. So while this is a sad day for me, it's a great day for the county because Jeremy's going to be transferring over to the health department. And I know Erica, the health department director, is kickstarting or increasing the staff for the healthcare informatics team. And this is really, I think, a great place for everybody to start centralizing some of this data, like we just saw that the ME's office is doing down in King County for the region. And so Jeremy in particular, and Amy Hockenberry, who's leading that group, I know we're going to energize on that. And I think it's a really good way to bring in the law enforcement data, the EMS data, the mandatory reporting data from the hospitals related to overdoses and what goes through there. So you'd have a really good community snapshot of what's going on. And so hopefully I'll find somebody as sharp as Jeremy back in the EMS office, but I think you'll see some integration, a higher level integration of all this information from his work. And what he really is exposed, from my point of view, is a huge gap into understanding why all this information needs to be collated. It needs to be in a central repository. And obviously I'm kind of pushing for this idea of a integrated health information exchange or community information exchange so we can all share this information.
Mike, I'll add my thanks for presenting this. I agree with Mike Smith how interesting and valuable it is. I'm glad you're sending it to Jill. Sorry about Jeremy, but I'm really excited about the health department informatics team developing, because that could be an answer to or a resource for a couple of the problems the task force has been dealing with. And I also want to thank you personally. I know you had a hand in convincing Dr. Hunt to start reporting into this state collaboration. And so thanks for doing that.
You know, on a general note, yes, thanks so much, Mike. And I just wanted to add, if folks haven't, I'm currently finishing reading a book by Sam, I believe I'm pronouncing his last name correctly, Quinones, who wrote Dreamland. If you happen to have read that relative to fentanyl and et cetera. I'm just finishing his, I think it's his most recent, is called The Least of Us. And it really makes reference to methamphetamine and also the production of methamphetamine and how the production of that has changed, and on a molecular level, chemists and so forth, that it's no longer requires getting the ephedrine that we're familiar with and what they refer to as a shake and bake method of manufacturing methamphetamine, that is no longer required, because what happened was, of course, legislatively, they limited access to the ephedrine. And so now, and for the last several years, methamphetamine production has been very different. I've just found that really, really informative from a larger picture of where is this coming from and what is going on, and why are many of our methods of approach, handing a card to somebody, as we had talked about, and hoping that they will take that that opportunity. And he actually ends up addressing it. It's a fairly long document, but at any rate, it's worth reading if you haven't read it. So I'll stop there.
Thanks, Perry. Yeah, it's on my copy table. I just finished it. The meth that Perry's referring to is phenyl 2-propanol is the name of it, and it's it can induce psychosis on the first or second use. It's really dangerous. So what's happened, just as a means of context real quick here, is the cartels figured out they moved away from plant-based drugs, so marijuana, cocaine made from cocoa leaves, opium made from poppy bulbs, and moved over to this new type of meth. I think it's based on old biker meth from the 70s, but it's highly controlled and manufactured in facilities, and same with the fentanyl. And so they've moved away from the plant-based and they've moved towards things that they can manufacture that don't require like a growing season, for example. And we've seen the results of that here. Mike's gone over that pretty well. And Mike, thanks for being Hilly, for being a proponent and getting the data. I think that Whatcom needs to have that data. But what we're seeing, we just saw a bust of 91,000 pills not too long ago here in Whatcom County, and we're seeing street level busts of lower amounts. So it's just disconcerting that we have this in our community, and having to Narcan people back to life is really troublesome. Mike, Hilly, I wanted to ask a clarifying question. You had mentioned fentanyl strips. Can you explain for the public what that means?
Yeah, thanks, Dan. And I really haven't had a conversation with the health department about this, and I'm not even sure they're really doing it at the state level, but there has been a bit of push in other areas where not our state that I know of yet, where regions or communities will provide fentanyl strips along with the needle syringe program. And the training is that test your pills, test your drugs before you take it, so you can see if it's positive for fentanyl. I don't know if the strips can tell you what the potency is, but it would let you know that, for example, a blue 30 pill that's billed as a Percocet actually really has fentanyl in it. So I don't know if that's a possibility in our community, but that was back to one of the reasons that training is tacked on and into that SAMHSA grant, is that from the federal point of view, they'd like to see fentanyl strips pushed out into the community to see if they can increase edge of safety, a harm reduction idea of just increasing safety if you're actually going to be shooting drugs, so you know beforehand what you're getting into. So we'll do that training, but the backside of that is I don't know, and Perry may be closer to this, if there's an idea that we would be doing fentanyl strips in the community anytime soon, maybe through a state distribution or something like that.
Dan,
Yep.
Chief Snake and Stephen Gockley have their hands raised.
Go ahead, Chief.
Yes, thank you. So to Dan's original statement about the Blake decision, so I am on the HCA Substance Use and Recovery Services Advisory Committee. That is the response to the Blake decision. And I would extend the invite, of course, to anyone on this committee to join one of those meetings. And if you're interested to hear what's going on with them on the decision filters and the recommendations that the HCA plan, or it's right now, they're trying to gather the information to do those recommendations. Of course, no one wants another meeting, but I do think it's an opportunity to hear kind of what's going on. So if you're interested in that, I could send you the schedule.
Thanks, Tank. Sorry, a big dump truck is driving by. Stephen Gockley, go ahead.
Thanks, Dan. Mike, a couple of days ago, there was an article in the Seattle Times about how across the country, and we're seeing it now in Washington, they're finding a drug called Trank mixed in with a lot of other drugs, and it's pretty potent in its own right, and sort of basically puts people to sleep almost immediately. Are we seeing that locally that you're aware of?
Not that I'm aware of. I'm having usually we'll get an idea from our medical program director if there was a one-off or something that was a tricky, especially when related to toxicology on the back end. But as of yet, I haven't heard of any, for lack of a better term, non-traditional overdoses with what we saw in that report. So, but we'll keep an eye out on it, and I'll ask Dr. Wayne to kind of mention that during our CE to report if they'd see an unusual overdose with that mixture that you're talking about. I'm not familiar though at the moment.
Great, thank you.
Mike Smith.
Yeah, just kind of springboarding off of Mr. Gockley there. In Tacoma, a lot of times, in Seattle as well, in the African American community, the trank is a lot of times what they mix with PCP. They call it SHRM, you know, wet, that type of thing. And so there's probably a lot of overdoses that are happening that are not being documented, but what they call it in the community is getting stuck. The person is stuck. They're so over tranquilized, their systems can't function, and they're kind of, I would say, zombie-ish like. You feel really thick and you're just kind of stuck in this mode. And so they run around with mustard and milk, and they give them a lot of milk and they give them mustard, and they say that brings them down and it helps them. I don't know, you know, medically whether that actually helps, but they swear by it in the community, right? I've seen it 1,000 times. So yeah, it's been around for us a while. It's like elephant tranquilizer, horse tranquilizer. But it's a mix with the angel dust, and then it's called PCP, and then it's called SHRM, and so forth and so on. So it's probably happening. It's just not being reported probably.
Yeah, and good point, because I've seen that as well over the years, where we have interestingly formaldehyde dipped marijuana cigarettes, or even a regular cigarette dipped with formaldehyde. And then of course there's the ketamine issue too, right? People are playing with ketamine and using that to smoke and party. And then on some rare occasions, actually, and I don't know how people get this, but propofol of all things, where people are able to get propofol and abuse that as well. So Mike Smith's right. Sometimes we just don't get that in the weeds reporting on what it is, and it's more just of what you're hearing on the street that people are doing with it.
Mike Smith, I'm wondering if carfentanil, which is like a horse tranquilizer or a large mammal tranquilizer, is that the trank that, or is that part of the picture as far as you know?
Not that I know of. Trank's been around since in the African American and Hispanic community. I grew up in Los Angeles, so that it's carfentanil. I didn't know that was ever around until recently. I don't know how new of a drug it is, but that was something that they weren't able to get their hands on. It mostly was just like the animal tranquilizer, but it could have been. I just never heard the language of it.
And you had mentioned a couple of street names for trank. I think, did you say Sherman? There's another one that you mentioned.
SHRM, yeah, SHRM was because they used to take the embalming fluid or formaldehyde, and they would mix it with all these different tranquilizers, and they would dip it on what they would call Sherman cigarettes. It was a green pack of cigarettes. They were a brown cigarette, like a Moore, and they would dip it, and then that's where the word SHRM came from. But when you became too intoxicated, your body would overheat and you would get naked. So then the street language would be called butt naked. They would call it butt naked or roof juice, because you get on the roof, you think you can fly, and all this type of thing. What actually happening is the person is actually overdosing. You become hallucinate, you start to hallucinate, that type of thing. So, but yeah, I don't know as far as like carfentanil, like how that played into that. That's pretty new to me. But yeah, I mean, we see it definitely though.
Thanks, Mike. Committee members, any other thoughts or comments? Scrolling through here.
Yeah, Dan, I had a comment just in response to the concept of harm reduction with fentanyl strips, because I know we've had reports from our treatment agencies that they are seeing that people are using fentanyl strips to ensure that fentanyl is in the product because they want to use it, and then secondly to reduce, sort of lower their tolerance so they can use more of it. So far from a harm reduction sort of policy, I think their belief is that it's endangering people to put fentanyl strips on the street. So many of them are not using that tactic.
Yeah, and Mike, I know that you didn't, Mike Hilly, I know that you didn't mean it in this way in terms of the fentanyl strips and harm reduction and things like that, but I don't know, like to me, harm reduction and fentanyl should never be used in the same sentence. I think it's such a dangerous drug. I thought that the new meth was going to be a real issue, but in talking with law enforcement, with the Bellingham law enforcement, they're seeing fentanyl as the primary drug, at least in this community. I know that your graphs and your charts show some poly use, and I understand that. In speaking with someone who used to work in narcotics, one of the officers, he said that before the Blake decision, he would be able to, bust a user, and then have that person kind of go up the chain to their dealer, the street dealer, and then the street dealer would go to the larger distributor, and then they were able to make those arrests at higher levels and keep drugs off the street in that way. And that's not possible anymore. So it's unclear to me in terms of the enforcement side how things are working, other than that it appears that the drug enforcement task forces are making these larger arrests occasionally, but when it comes to the reduction of harm at the street level, I just I don't know how that works. And so I feel like I said this before about uncharted waters. I feel like that's exactly where we're at, and it's worrisome to me to have people with a mental health illness who are using. And Jackie, what you just said was, I'm glad that you said that. Thank you for saying that. And it's very disturbing to hear that people would use it for the exact opposite, the strips for the exact opposite of the intended use, to see if there is that drug present. So I don't know. I wish I had better answers here today, but I think that this is the continuation of the exploratory part of our task force's work, and seeing what we can do to divert people to treatment. And Perry, thanks for your presentation with the what I would regard as more hopeful information in terms of the infusion of dollars. I know it's going to take a little while for that all to happen, but at least there's a little bit of a glimmer of hope here. I'll stop talking. Committee members, any other?
And I just want one comment. Yeah, and I appreciate your perspective on that. And actually, Jackie does offer, the considerations on what a policy would be, on fentanyl strips alone, because I don't think I've ever heard a policy decision on that. And I'm sure that's why really, that's even at the state level, that's not gotten into it. But, this is a similar conversation that we had when we put Narcan in the hand of civilians and non-medical people. There are a lot of people that thought that, no, this is just going to increase use. This is going to put a lifeguard at the party, and then people will feel much safer using it. So I think from an EMS perspective, it's just more about how can we reduce death from ODs. And as we talk about these policies, is that one way. But you're right. Druggies can figure out better uses for things that most of us wouldn't have considered down the line, some of that stuff. So yeah, it is a mixed bag. And I think that's why I sit back and wait to see if there will be a policy decision, and if that's something that's going to be useful in the state. I just don't know.
Yeah, gotcha. I hear that. I think the other thing that we're not talking about today is the attendant property crime that is associated with drug use. And we have a hardware store here. It's a chain store. It's a national chain who have seen basically a twofold increase in theft. And my wife and I witnessed it. We were shopping for a plant, and this gentleman pushed a shopping cart full of power tools running out of the store, and was stopped by a civilian person. And the person who was stealing just walked away. Basically, when the civilian grabbed the cart and said, "You're not going to take these things." And we're seeing that kind of anecdotally over and over again, where people are they're going into places and stealing things and saying you can't do anything about it. And we've seen a marked increase in the hiring of security guards. There's a former Snohomish sheriff's deputy who is a armed guard at Fred Meyer on Lakeway. And it's a different world. It's really a different scenario. So I don't know what Mike Hilly, to your point, I don't know to what extent policy changes are going to affect this, but yeah, something's got to change here. This is not helpful for the people that are using and the people that are being victimized via a property crime. So I guess stay tuned on that one. Committee, anyone else want to chime in here?
Yeah, I just wanted to say, and to Mike, I agree with you. I think it needs to be looked at it from a broader perspective, but I think we're doing one of the best things we can do by marrying up behavioral health clinicians with law enforcement and EMS, but you know, kind of as soon as we get a workforce, kind of putting them out everywhere that we can, and addressing both some of the underlying issues and getting them engaged in whatever services we can get them engaged in, whether that's treatment or housing or whatever. I think we're doing one of the best things we can do by amping up that workforce. And we'd have to marry that, I think, with things like, you know, Narcan distribution and if we were to, you know, do something like fentanyl strip distribution of some sort. I think it's the best all around when we kind of infuse a situation with as much human capital as we can. Anyway, that's my opinion.
Thanks, Jackie.
To add to what Jackie, you know, was saying there, and you know, I'll own my my history and background as far as I'm an old drug and alcohol counselor, and I think that one of the real challenges, and we've spoken about it to some extent in this meeting, is that component of accountability. Individuals that are struggling with addiction to the kinds of substances that we're talking about, methamphetamine that is typically infused with fentanyl, and fentanyl itself and other opioids, it isn't a decision to stop using. It is the process of addiction is likened, in my opinion, to stepping off a cliff and then saying, why don't you stop falling? That it simply isn't a decision on that person's part. And so components of accountability, and oftentimes individuals entering into a crisis, what they're experiencing as a crisis, is oftentimes the only moment of where that individual will, in consideration and sometimes admittedly manipulatively, will accept an assessment or some kind of process. And I used to certainly say in my clinical work that I don't care what brings the person to the table to give consideration to an assessment or engagement in some kinds of services. That didn't matter to me. The fact that I was able to have that contact, that communication, and begin to move or expose that person, however many times it took, to the resources that are available, you know, relative to recovery, was extremely important. And that lack of accountability factor that seems to really be present, you know, at this point, and the developing consequences from that definitely plays a component in individuals continuing to use and then ultimately dying. So, Dan, not to attach my belief system and thought process to something that you said, but that it's like really, you know, taking a look at harm reduction and fentanyl being used in the same sentence. Oftentimes, what we're talking about is death before that can occur. And so that certainly concerns me. And I'm not necessarily talking about going from 0 to 60 in terms of accountability and that sort of thing, but beginning to take a look at how can we, you know, continue to motivate individuals towards at least accepting some recognition of what's happening for them. And some of this admittedly is coming from my reading of this book that I was making reference to, because the author certainly makes reference and says, we're dealing with a completely different drug here than we ever have before. And individuals making a healthy and conscious decision while they're actively using just isn't very likely. And I tend to agree with that. So I offer that thought process. However, popular or unpopular it may be.
Thanks, Perry. Just quick side note, Stephen Gockley, I think we need to, when we're talking with our communications consultants, we need to integrate some parts of this discussion in with them. This is a little bit, I wouldn't say granular, but I think it is drilled down a little bit. But and I don't know quite how to do that, but I want to make sure that the public understands that this task force is very cognizant and aware of these new dangerous street drugs, and we're trying to come up with some solutions. And we have some options, but I don't know if you have any thoughts on that.
Well, I liked what you said earlier, your 30,000-foot framing of helping the public understand that the way we're responding to these situations is notably different than it was even a fairly short while ago. But yeah, what you're speaking to now is a different component of that, and I think, you know, I'm a lay person, so I'm not sure I get the granularity that you're referring to. But one of the things I take away from these conversations is how creative, entrepreneurial, and nimble the drug distribution and manufacturing system is. So it's like almost every 2 months you hear about something new on the street, and people gravitate to that immediately. So there's a sense in which a lot of times it feels like we're always behind the curve. But I do think both that dynamic of how rapidly changing that market is, and the fact that we're doing our best and have some tools to try to keep up with that and respond to that, I think those would be valuable things to communicate, Dan. I agree with you.
Okay. Mike Smith.
Yeah, I just want to say this is a very good conversation. I really appreciate the passion and the vision that everybody has here to help guide the community to a better place of healing. And like Mr. Perry said, working in the field, trauma-informed lens, these folks are doing the best they know how, right? I mean, a lot of them want the best drugs. Unfortunately, the best drugs are the fentanyl. That's what they want, right? That's the high that they're looking for. They're not looking there may be some that want to use a test strip to make sure they don't overdose, but ultimately, that's the point that they almost really want, right, deep down inside. And that's the sad, unfortunate part of substance use. I do want to, from a macro view, I mentioned my upbringing, and I grew up in a different type of community. And so I just want to talk about narcotics, period, substances, period. There is a cultural lens to these narcotics, right? Some, like you'll catch the Hispanic population using more of the brown tar opiates that cause a lot more abscesses, and it doesn't really heal and that type of thing. And so you just see various components, like the African-American community is still using cocaine, still using crack. Crack is higher to purchase right now. Meth is a lot cheaper. So you see them doing that, but you see the older generations still using cocaine. Yeah, I remember when meth was just a European thing, a white folks narcotic, right? They would say in the hood, right? And so just looking at it from all these cultural lenses, putting a model together should have that lens as well, because you're not going to really reach the other folks if we're so over concentrated in one area. But the thing about fentanyl and opiates and meth, it's like it's spread, generally across everywhere. So I just wanted to kind of put that piece in there just so that can kind of be said.
Thanks, Mike. That's super helpful. I think that's really important to those cultural considerations are huge, and they do need to be discussed. So thank you, Mike. The community appreciates that. Other thoughts? Okay.
Dan, I would just, I also appreciated Mike's comments. I think that loops back into the money and the workforce support and workforce development kinds of initiatives that we were talking about right at the outset. You gotta blend the two together to be effective.
I agree. I think I wonder to what extent. Sorry, there's a big truck going by. In terms of our GARE work, and when we think about diversity, equity, and inclusion, Mike Smith's points are very well taken. I mean, I think that's, if we're not looking at it through the cultural lens, pardon me, then we're totally missing the point, we're missing funding opportunities, we're missing the application opportunities. So I think that that's those have to be brought up. So thanks, Mike. And I think we just need to stay on course when it comes to the toolkit, basically. So when we're talking about, you know, these types of drugs or these types of programs for intervention, what does it mean for BIPOC community members, and what are the impacts there? So yeah, okay, all right. Other thoughts? Okay, I'm swiping through it. I'm not seeing any hands. Jill, does that take us to the end of the agenda?
It does, yes.
Okay. So I guess we go to public comment now.
Yes, we don't have any in-person attendees in our conference room, and our virtual attendees are Jackie and Mark. If you'd like to speak to the task force again, please virtually raise your hand. And no hands are raised. And Dan and Stephen, if you have 5 minutes after the meeting to chat, that would be helpful. Thank you.
Okay. Thanks, everyone. I'll go ahead and adjourn the meeting. I don't know what time it is. I see a clock behind Mike Smith's head. I think it's 10 something, 10:30, 10:35. So anyway, we'll go ahead and adjourn. Thanks, everyone, for taking time today. Appreciate it. And we'll see you next time. Take care.